Hello, my name is Dr. Walter Maximovich, and I'm a rheumatologist and Chief Medical Officer of Care Arthritis. I'm also Professor of Medicine at the University of Alberta in Edmonton, Canada. It's my great pleasure to discuss imaging for the clinician and the evaluation of MRI scans in patients with non-radiographic axial spondyloarthritis. This is extremely important to the early detection of this condition. And we're going to do this by reviewing MRI scans and specifically DICOM images from patients attending my clinical practice. DICOM imaging is the way that this is done in real-world practice by radiologists, and it is extremely important that rheumatologists understand the principles of using DICOM imaging, the basic language of MRI, the key lesions, and the advantages of using MRI over plain X-rays. Before we begin, it's important that we understand the orientation of MRI images. MRI images are conducted in an orientation that is parallel to the posterior border of the second sacral segment. And the imaging is conducted in a series of consecutive 3 mm slices, the total being about 15 to 20 slices through the cartilaginous portion of the sacroiliac joint. It is important that the imaging is conducted in this manner because this allows the optimal depiction of the cartilaginous portion of the joint. If you would like to download the image acquisition protocol for appropriate diagnostic evaluation, this can be done from the Care Arthritis website. It's important to state on the MRI requisition form that you are requesting a T1 weighted and a STIR semi-coronal scan of the sacroiliac joints. And for routine diagnostic evaluation, and especially in non-radiographic axial spondyloarthritis, it is sufficient to just evaluate the sacroiliac joints. Now, why do we conduct the evaluation with this orientation? The cartilaginous portion of the sacroiliac joint is approximately a C-shaped structure. The synovial portion of the joint is in the inferior third, and it borders the rim of the cartilage. And it is extremely important that we see as much of this structure as possible, and hence this is why we image this portion of the joint in the semicoronal orientation. Posteriorly is the ligamentary portion, and so in fact the ligamentary portion of the joint will first appear in the middle of the joint as we go from slice to slice from the front to the back of the joint. Now let's look at this using DICOM imaging. So we're going to go now and first of all look at a healthy joint. And we have the T1 weighted image on this side, the left side, and the STIR image on the right side. And this is now DICOM image viewing. And what I'm using is the DICOM image viewing software. And as I scroll through the joint by clicking on these arrows, we go from slice to slice from the front to the back of the joint. Now, the T1 weighted scan is a fat sensitive sequence. So this means the subcutaneous fat is very bright. The STIR sequence is fat suppressed. So you can see that the signal from fat is suppressed. Now, why do we need that? Well, there is fat in the adult bone marrow, and it may obscure water signal from bone marrow edema related to inflammation. And so this is why with this sequence we suppress the fat signal. Now, in addition to being a fat suppression sequence, the STIR sequence is also a water sensitive sequence. So for example, we can see the signal from the water in the pre-sacral veins. And we can also see the water at the back of the joint, the cerebrospinal fluid. So the STIR sequence is both fat suppressed and is water sensitive. And bone is dark on both sequences, and you can see the cortical bone is outlined against the bright gray consistency of the bone marrow. The DICOM image viewing software allows you to magnify the joint, and in addition we can alter the brightness and the contrast, and that's what should be done to optimally view the sacroiliac joint. And we can see as we scroll from front to back that first of all we do not have erosion in this joint, because we have two dark parallel lines indicating that there is no erosion. And then as we go slice by slice with it, we again see that we have two nice parallel dark cortical lines. So there is no erosion in either the right or the left sacroiliac joint. And then we enter the ligamentary portion of the joint. Ligament, like bone, is dark. So these dark dots reflect ligament. The bright signal on the T1 weighted sequence is fat in the ligamentary compartment. The bright signal on the STIR sequence is fluid, and is fluid in the blood vessels. So this is what we see in the posterior part of the joint as we scroll from anterior slices to posterior slices. Now what we're going to do is look at what an abnormal joint looks like. And this is a 42-year-old patient of mine who'd had back pain for 3 to 4 years and then went on a trip to the Caribbean, and he ate something that did not agree with him, and about a week or so later he presented with joint pain. He had some mild diarrhea the day after eating this food, and then a week later started to develop some joint pain. And then 3 weeks later had really quite severe exacerbation of his lower back pain. So here we have his pelvic radiograph, and in particular this is a Ferguson view where we can see that sacroiliac joints in quite some detail. We're going to increase the brightness and make the joint margin as sharp as we can, which we can do with this DICOM viewing software. And we see that there's overlying gas shadow on the right side, which makes this joint rather difficult to evaluate. But on the left side, we clearly have some sclerosis of the iliac bone, and we have erosions and irregularity of the left iliac cortex. So when we look at the MRI scan now, and what we see on the MRI scan, the T1 on the left and the STIR sequence on the right. Just going to make the picture as good as it can be. And you can see that as we scroll from the anterior to the posterior slices, that there is this bright signal on the stir sequence. And what this reflects is severe bone marrow edema in the left sacroiliac joint. We also see this bright signal on the superior aspect of the joint. The patient has a capsulitis. There is bright signal in the joint cavity, and this reflects joint fluid. You can see some widening of the joint space on the T1 weighted scan because the patient is starting to develop erosion of the left iliac cortex. So this is what an acute sacroiliitis will look like very clearly on an MRI scan. It's very important that we also understand the differences between the information provided on an MRI scan and, for example, a CT scan. And this case will allow us to compare a CT scan with an MRI scan. On the left, we have the T1 weighted scan. On the right, the stir sequence, the stir scan. We're just going to make this scan a little brighter and a little sharper. And as we scroll from anterior to posterior slices, we see that this patient has bone marrow edema in the left iliac and sacral bones, the right sacrum, and the right ilium. But what we also see is that this patient has evidence of erosion. And we can see the erosion very nicely outlined in the sacrum using this annotation. So this is an example of both active inflammatory and structural lesions. The dark signal that we see in both iliac bones, you will recall that bone is dark on an MRI, and this reflects sclerosis in the iliac bones. Now let's look at the CT scan of this same patient. And we're going to get the CT scan in the same orientation and approximately the same slice as the MRI scan. And what we can see here, and we can optimize the image, the DICOM CT scan image, just like we do the MRI scan. And now we see very clearly on the CT scan the erosions of the sacrum in the right side and the left side, and what this looks like on the corresponding T1 weighted scan. We see how the dark signal illustrating sclerosis on the MRI scan is depicted by this bright signal on the CT scan image. So that is how sclerosis and erosion looks like on an MRI T1 weighted scan. Now it's also important that we understand the sequence of changes over time, because lesions change, and when you order an MRI image, the appearances will of course vary over time. Now this patient is a very interesting young man, a 22-year-old man, whose father is an old patient of mine with severe ankylosing spondylitis. And this young man came to see me with an 18-month history of ankylosing spondylitis. He in fact presented with inflammatory type back pain, and it was really quite characteristic of spondylitis. So what did his x-ray look like the first time he came to see me? So let's focus on just the X-ray. And this X-ray shows the right side is completely normal. The left side shows sclerosis, and it shows some irregularity of the iliac cortex. We might consider this a grade 2 according to the modified New York criteria grading scheme for radiographic sacroiliitis. But this clearly does not meet modified New York criteria because the right side is normal, and for the modified New York criteria, bilateral grade 2 radiographic sacroiliitis is required. So this patient in fact presents with non-radiographic axial spondyloarthritis. These findings are very suspicious for spondyloarthritis. So this gentleman was in fact quite keen to participate in our research study, and this required that patients have MRI scans done every year. So let's have a look at his baseline MRI scan. So the T1 is on the left and the stir sequence is on the right. Let's make this image much brighter, and we'll do this on the stir sequence as well. Let's magnify both scans, and let's review each scan slice by slice from anterior to posterior. Now as we go slice by slice, and let's look at the stir scan first, we see that there's a very clear bright signal in the left sacrum. So this patient has bone marrow edema. It's evident in several slices, in at least 4-5 slices. So this is unquestionably typical of axial spondyloarthritis. But there is more than just bone marrow edema in the left sacrum, because if we magnify the T1 weighted sequence, and let's just make the image a little brighter and a little sharper, we can see that the margins of the left iliac bone are actually quite irregular. Now, this patient has erosion. There's also erosion of the left sacrum, very irregular. And there's widening of the joint space because with the erosion, there is loss of the marrow matrix. And indeed, there is also some sclerosis. There is dark signal in the left ilium. There is also bright signal in the joint space. So this is reflecting an active erosive process involving the left sacroiliac joint. It was interesting that this patient was managing his symptoms with only the occasional use of over-the-counter ibuprofen and did not feel that anything more was required. He came back to my office to see me a year later, was still feeling quite well, and so we, per protocol, repeated his MRI scan. So what did his MRI scan look like at this point? So the MRI scan has now clearly changed. As we look at the scan and scroll through the slices, we see that the bone marrow edema has disappeared. And what do we see instead? We see bright signal not on the stir, but on the T1 weighted sequence. What is this? This is post-inflammatory fat metaplasia. This is what occurs after inflammation resolves. You can see that this is bright signal adjacent to the subchondral bone of the sacrum. It is homogeneously bright and it has a distinct border. And this is what is characteristic of post-inflammatory fat metaplasia. We also see bright fat signal in the joint cavity. And in fact, the bright signal, the fluid signal in the joint cavity has also subsided. And we're seeing fat signal in the joint cavity. So this is fat metaplasia in an erosion cavity, or otherwise known as backfill, the infilling of an erosion cavity, a term borrowed from the construction industry when you're building a house and you have a hole to lay the foundation in the ground, and you refill the hole with dirt to pack the dirt around the foundation. This is an analogous situation in the erosion cavity. This patient was still feeling very well, and again only taking ibuprofen as required. And now he comes back a year later and circumstances have changed a great deal. He is now extremely symptomatic, has been taking ibuprofen in doses of up to 3.2 grams a day, and also taking naproxen 500 milligrams twice daily with very little impact on his symptoms. And he is using a walking stick because of the severity of his spinal symptoms. So what do we see now as we scroll through the slices from front to back? Now we have an intense bright signal in the right sacrum. We have some signal in the right ilium. There is a very active inflammatory process in the right joint. We also see very bright signal in the joint space with some widening of the joint space, and this patient has erosion of the right iliac cortex. And as we go slice by slice, we again see this marked irregularity of the right iliac cortex. In fact, we can look at this in a great deal of detail using DICOM imaging software. And as we look through at the images, we see this very, very irregular iliac cortex. And it almost appears to have a sawtooth appearance all the way down the vertical height of the cortical bone. So this patient now has a very active inflammatory erosive process. So it's very important that we understand the sequence of changes. It's possible for you to do the imaging when the patient only has fat metaplasia. We're now going to look at the scan of a patient who actually is a police officer. He's 35 years old, and he is a police officer who was actually doing some work at home. And he fell off his ladder several years ago, but has had persistent back pain. And his back pain does not seem to have resolved after 3 years. And his back pain has some characteristics of inflammation, specifically morning stiffness and pain at night. And there is little to find on physical exam. He is B27 positive. His CRP is slightly elevated. CRP is not a particularly sensitive biomarker in early disease, especially non-radiographic disease. Here is the patient's pelvic radiograph. The question that we're asking again, does the pelvic radiograph show sacroiliitis according to the modified New York criteria, which stipulate bilateral grade 2 or unilateral grade 3 is required. So here is this joint. We can try and optimize the picture. We can magnify, and that left joint looks normal. The right joint does look abnormal. There is some sclerosis. There appears to be some erosion of the sacrum, but it does not meet modified New York criteria. This is a grade 2. The left side is normal. So again, this patient has non-radiographic axial spondyloarthritis. Now, the imaging assessment here is crucial because this patient has tried several anti-inflammatory drugs and still very, very symptomatic. His Bath ankylosing spondylitis disease activity index score, the BASDI, is 6.5. So he actually, in many jurisdictions around the world, would be eligible for expensive biological therapies. And we have to make a determination based on his imaging if he should be treated with a biological therapy. Does he have axial spondyloarthritis? So what we see as we scroll through the imaging from front to back is that on the stir sequence, there is relatively little to find. There may be a small focus of bright signal here. Is that bone marrow edema? There's relatively little bone marrow edema. Let's just magnify the image a little bit further. So now we have some doubts whether this patient has axial spondyloarthritis. But if we look at his scan, and particularly the T1 weighted scan, we see it's very abnormal. He has erosion of the right sacral cortex, erosion of the left ilium. And as we review all the slices, we see, and let's magnify the right joint, we see that the right lower iliac cortex is very irregular again, giving the appearance of a sawtooth appearance to the cortex. So he has bilateral erosion. And in addition, he has this incredibly characteristic post-inflammatory fat metaplasia with a distinct border adjacent to subchondral bone. So it's important for clinicians to understand findings on both the T1 as well as the stir sequence. It's not good enough to just be able to detect bone marrow edema. This patient, in fact, has an erosion of the left iliac cortex, and the bright signal is within the erosion. So this is, in fact, an erosion and an inflammation in the erosion cavity. So this patient does indeed have axial spondyloarthritis. And even though there isn't much bone marrow edema on the pelvic MRI, these patients may indeed respond to a biological therapy. So it's very important to make this diagnosis. This MRI evaluation can be transformative for this patient's life. Now let's have a look at another case, and we're going to look at the case of a marathon runner. And this young man is 28 years old. He's been running marathons for several years, but in the past 18 months has not been able to do this. He has significant back pain despite taking 2 non-steroidal anti-inflammatory agents. The back pain is of an inflammatory nature, and he has a BASDI of 6.3. He's B27 positive, but his CRP is negative. So what does this pelvic radiograph tell us? Not a great deal. Does the pelvic radiograph indicate sacroiliitis according to the modified New York criteria? Definitely not. The right side looks completely unremarkable. The left side may be a little bit of irregularity of the left iliac cortex, but really not even a grade 2. So now let's have a look at his MRI scan, and let's pull down the MRI, the T1 on the left and the STIR on the right. And again, we're going to magnify and review the scan slice by slice from front to back. And let's just have a look at this scan. And what we see is that this patient has bone marrow edema in several slices as we go from front to back. We see it first at this quite anterior slice in the sacrum. And then we see it in the right lower ilium, the right lower sacrum. We do not see a great deal on the T1 weighted scan, except for anteriorly, on one particular slice, there is a small erosion with some widening of the joint space. So this patient has bone marrow edema on at least 3 to 4 slices, several slices all the way back to the posterior part of the joint. He started on a biologic. He feels very well. He comes back to have his MRI scan repeated. This is not necessary, but it was done as part of a research protocol. And what we see is that there is indeed disappearance of his bone marrow edema as we scroll from front to back. Disappearance of the bone marrow edema commensurate with the substantial improvement of his symptoms. So the MRI scan here was absolutely decisive in transforming this patient's life. I will show you one more case, and this will now be a young woman. And this young woman is a dental hygienist. She's 29 years old. She presented with having had an attack of acute anterior uveitis. And she went to see her ophthalmologist, who inquired as to the presence of back pain. And she reported 18 months of right lower back pain in the region of the right buttock. And it was of an inflammatory nature. Interestingly, the B27 was negative and the CRP was negative. But the clinician had a high index of clinical suspicion based on the history of acute anterior uveitis and inflammatory back pain characteristics. Let's just magnify this pelvic image so that we can see the pelvic radiograph more clearly, and especially the sacroiliac joints. The left side is completely unremarkable. The right side is a little more difficult to interpret because of overlying gas shadow, but I don't think that we can say that there is a definite abnormality. So now let's have a look at the MRI scan. The T1 on the left, the STIR sequence on the right. And we will magnify both images and we will review the slices from front to back in a contextual manner, both the T1 and the STIR being viewed simultaneously. This is a key principle of MRI evaluation. And as we scroll from front to back, what do we see? Well, let's keep our eyes focused on the right sacroiliac joint. There's little to find on the left side. So I'm now going to magnify the scan, and we're going to look in particular at the right joint. So let's focus our attention on the right joint. And we see that the right joint demonstrates erosion. It's abnormal. There is widening of the joint space. There is very little bone marrow edema, just a tiny strip in the right lower sacrum. That could be a false positive. And erosion, however, is highly specific for axial spondyloarthritis. Small degrees of bone marrow edema, particularly in the anterior sacrum, can be seen in early osteoarthritis. But this patient very clearly has erosion that's visible on several slices. We can see that there is almost a punched out defect in the right lower ilium. We see it again in another slice. So when we see it in at least 2 slices, we can be confident that this is a definite erosion. And here we can see this in at least 4 slices. There is also some bright signal in that erosion cavity. And so this patient has inflammation in an erosion cavity, which is highly specific for spondyloarthritis. We will stop at this point, and I will just take you to a very important learning resource, the Care Arthritis website under Education, and the International MRI online course in spondyloarthritis. And there are many cases to view of patients who have had DICOM imaging, and the course is structured in a way that allows you to study in your own time and at your own leisure. For those of you who prefer to do it in Spanish, Portuguese, or Mandarin, that is also possible. And I would encourage you to learn how to interpret MRI sufficiently that you can engage in an informed dialogue with your radiologist. I hope very much that this will be helpful to you and to your patients. Thank you so much for your attention.